comes with us as a student at York University here in Toronto, and she moved to Canada from Portugal when she was 15 years old, and is proudly the first person in her family to attend post-secondary education. As an immigrant to Canada, Bruna saw firsthand how the system is unfair and biased, and those experiences led her to do the work that she does today. She's a member of the S4 Collective, a group of amazing people who see education as a right regardless of immigration status, and they'll be a big part of tomorrow's session. She's also a part of Vivemos Juntex and Comemos Juntex, where she actively tries to advocate for and help immigrants who have just arrived to the country and might need some guidance through the various aspects like finding housing and other supports. Bruna is a member of Food Knows No Borders, a particularly important project right now, which started about 3 months ago, where she helps deliver food boxes to undocumented persons, as well as members of the LGBTQ community and Indigenous communities in need. Bruna and Nico, please take it away.
Hello, everyone. Welcome. I hope you guys enjoyed today's panel. I will start by introducing our first two speakers. First, we have Najla Banai and also Rebecca Sheff. Najla works at the South Riverdale Community Health Center as a client care coordinator and has worked over 12 years with the community health. The bulk of Najla's experience has involved supporting individuals experiencing precarious immigration status. She has a thorough understanding of settlement issues, systemic barriers, and the social injustice faced by uninsured communities, and is passionate about the mental health and well-being of her clients. Najla advocates on a systemic level while also providing intensive frontline work to reduce barriers to healthcare and social services. Then we have Rebecca Sheff. She's a researcher at Wesley Institute, a health equity think tank in Toronto. Rebecca combines research, policy analysis, and stakeholder combining to advance strategies for change. Rebecca and Najla are co-chairs of the Health Network for Uninsured Clients, which brings together over 200 providers from across Toronto to improve access to healthcare for people without public health coverage, regardless of immigration status. Welcome, ladies. I will start by asking Najla the first question. In what ways has COVID helped or hindered your work or advocacy?
Thank you. Thank you for having us here today. So overall, I would say that yes, COVID, and since the pandemic has started, has been helpful in assisting us to support people who are living here without precarious immigration status and who need access to healthcare. I do want to say at the beginning that in Canada, the way healthcare is set up is that the province, Ontario that we're in, makes decisions about who's eligible for public healthcare coverage, and immigration status obviously is impacted by that and whether one is eligible or not. So it is provincial. With that being said, I want to talk about what our health network has done to create greater access for people with precarious immigration status. As a result of COVID, the health network organized quickly to ensure access to healthcare for uninsured individuals in Toronto. At first, our hope was to provide access to healthcare for COVID-related issues, but that quickly advanced beginning of the pandemic to include other healthcare needs people were experiencing. Health network efforts, which I'll kind of get into a little bit later, have helped people and frontline workers across our city to have a better access to knowledge and information and resources to increase access to healthcare. We knew it was important that we ensure seamless access to healthcare during this time, or there would have been really serious repercussions. The provincial government made our job a little bit easier. On March 20th, the Ontario Minister of Health directed all hospitals to provide medically necessary care to all persons who present at the hospital, regardless of the person's immigration status, so which would lead to them not having OHIP coverage or insurance. The care that they were providing was to be all medically necessary services and not just COVID-related care. This means that the patients without OHIP should not be asked for any form of payment when they walk into any hospital emergency room or are getting services within the hospital sector, as long as it's medically necessary, is how they phrased it. The directives state that the services for uninsured persons should be prioritized consistent with the prioritization of services for insured people. This particular statement in the directive was extremely helpful for us as an advocacy tool when we were later forced to kind of intervene in situations where people were still not getting access. I mean, this sounds awesome that we have the provincial government who has supported us by writing this directive and mandate. However, things didn't go as smoothly as we had hoped. Many hospitals interpreted this document to mean only COVID-related care, and were not aware of the directives as a result of uneven implementation within the hospitals themselves of the directives. Some just felt that the autonomy, they had the autonomy to decide and interpret what those directives meant, and would then relate that information to patients that are showing up in the hospitals, which was really problematic because it led to people being denied care or being forced to pay up front. As a result of this information, many individuals started to reach out to the Health Network for Uninsured Folks in Toronto, reporting the issues they were having within the hospital sector despite these directives that are put in place. The number of and the volume of people that were calling us and emailing us started to grow, so we really anticipated further barriers to hospital care if there was no intervention from our team. So once again, our network adapted quickly and we regrouped and developed what's called a rapid response team, a subcommittee of the Health Network. Our team consists of professionals with capacity and expertise to provide client direct care and navigation and advocacy supports to community members and service providers working the front lines. The team on a weekly basis provides virtual case consults with individuals, frontline providers in the community who are either denied care or need to know how to navigate the services for their own clients. We have also facilitated resource sharing, uncovered issues that are related to COVID-related processes. For example, despite the fact that the ministry said that you're able to access a COVID test, folks who were undocumented or uninsured were going to get these tests, but when it came time to get their results, you had to have an OHIP number to access the results online, and this became problematic. So our team worked quickly to help resolve this issue, and is now resolved, hopefully, as far as we know. But that's just an example of some of the things we've uncovered through this rapid response team, and how our team and working with the community has led to direct problem solving around specific cases that have been proven to be helpful. Some of the other initiatives we've been engaged in is a plain language guide related to the recent changes. We thought it was really important for the community to be aware of these changes, frontline workers, as well as folks who are living here with no insurance. They need to know their rights at this time. So many of us did a lot of outreach to inform people, and we developed this plain language guide that's available on our website. I think we'll post it in the chat in case people want to have a look at it. Also, some of us who work within community health center sectors reached out to folks that we know are uninsured, letting them know, hey, do you know about this directive? In case you are sick, here's what your rights are, and you are able to access healthcare. We thought that outreach was really important. We also organized outreach strategies to the hospitals. So Rebecca and myself, as the chairs of the network, reached out to hospital leadership in the city to make sure, one, that they're informed about the mandates, following the mandates, and if there were any specific issues or cases that were highlighted to us within a certain hospital, we were sure to bring it up with the CEO. And as a direct result of that, we got really positive and helpful outcomes, because if the CEO is confirming, yes, in fact, they are following this mandate, if on the front lines we were getting any pushback, we were able to present them with documentation that states their own hospitals accepting clients. So we found that strategy to be helpful. We also hosted a number of different webinars, including this one, where we try to do as much outreach as we can to share best practices and the current state of healthcare for uninsured people and how it's going. So definitely overall, I would say COVID has helped us strategize and quickly respond to the needs of the community in a way we never have before. Thank you.
Thank you so much, Najla. Thank you so much for your work. My next question would be for Rebecca. How can we build political consensus with different audience for campaigns to extend the rights of immigrants in healthcare?
Yeah, thanks for the question. So from what Najla was talking about, we're really in the phase of thinking about, now that this policy change has happened and hospitals shouldn't be charging clients, how do we make sure there's accountability and implementation so that clients feel safe to access that care, and that care is good quality, dignified, and that they're not getting billed. So that has really required a lot of partnership and outreach with people, for example, legal clinics, settlement immigration workers. We've done our webinars with a number of the associations of health providers. So we've worked a lot with the Midwife Association for Ontario, with the Community Health Center Association. We've reached out to the Ontario Hospital Association. We did a webinar with Mental Health Group. So really trying to reach different people working in the healthcare system and throughout hospitals, because they're so large. So we know that we're reaching the CEOs, but we also want to be thinking about people in all the different departments. In hospitals, we're also thinking about who might be our allies. So we often work with ethicists, social workers, health equity managers, to think about who it could be that we reach out to. And then we're also working a lot with advocates in the space. So OHIP for All is a big group, and they're able to have even broader networks. So that's just been critical for what we're doing. And then when we do those webinars, we make sure we have people in different roles and perspectives. So Najla is a social worker. I have the research policy perspective. We have lawyers, we have intake workers. So the information we're sharing is very pragmatic and really helps people in their roles supporting clients.
Thank you so much. One last question for you. What is the role of the city level governance in helping your work in these areas? Yeah,
it's a great question. So the city of Toronto, where we are, did declare itself a sanctuary city. The policy particular that they passed, which Graham has done loads of work on, was an access TO policy where people can access services without fear if they're undocumented, but that's just for city-run services. And healthcare is provincial jurisdiction. So all the funding is from our provincial government. So the city declaring itself a sanctuary city is very important. It's a very important value. We have really good partnerships with our city public health department and with the newcomer office there. And it's been an important advocacy tool to say this is, our city has declared this. But when we're thinking about advancing change for access to healthcare, we really have to be looking at healthcare providers and our provincial government.
Thank you. Thanks a lot. I'll take on and continue to introduce our next speaker. Now from Canada, we move to Europe, and I have the pleasure to introduce you Michelle Livoy, who is director of PICUM, the Platform for International Cooperation on Undocumented Migrants, which is a Brussels-based umbrella organization representing 167 organizations who work on ensuring the fundamental rights of undocumented migrants across 35 countries, primarily, but not only, in Europe. PICUM members range from human rights organizations, migrants' rights organizations, organizations focusing on children's rights, women's rights, access to healthcare, trade unions, faith-based organizations, and so on. And PICUM has the critical role of bringing the voice of the grassroots level to the European level in Brussels. And I'm particularly proud of introducing Michelle. Michelle is a friend as well as a great professional. I personally started my own career with PICUM, and I'm very proud of that because we can peacefully say that PICUM is the main NGO actor working on undocumented migrants in Europe. I think most of us, especially those working in Europe, know the campaigning and advocacy work done by PICUM at European level, and their numerous reports on undocumented migrants constitute the lighthouse for advocates, campaigners, and researchers on undocumented migrants issues across Europe. Michelle itself is PICUM. She was there since the birth of the organization, has been the director of the organization since 2006. And I think she's a great speaker for a transatlantic event like this. Michelle herself is originally from the US, but she has been living in Belgium, I think, for the last 20 years or more. So she has a great understanding of the both continents. But we'll focus now on Europe, and I want to give the word to Michelle starting by asking you, Michelle, if you can tell us a bit more about PICUM's work on undocumented migrants' access to healthcare in Europe in 2020, in particularly in light of the COVID-19 pandemic. We've heard how the COVID-19 pandemic has moved things around in Canada. What's your impression on what happened in Europe as actually the COVID-19 pandemic impacted on your work, impacted more generally on migrants' access to healthcare in the European continent, and how this has been helpful for your own advocacy or has been actually preventing you from doing advocacy on these issues? Thank you, Michelle.
Thank you so much, Nico. And I should recall that I gave you a very short bio. So thank you for that long introduction. It's great to actually be on this webinar with you and all the others. It was really wonderful to actually hear the previous speakers and to hear about your work in Toronto. So thank you to Rachel and Graham for organizing this and all the people who are watching. So in terms of how we as PICUM have seen how COVID has kind of helped or hindered our advocacy, we've seen that in general, COVID, as we all know, it's had a devastating impact on all of us as individuals, as societies, but the impact hasn't been equal. And it's shown that these inequalities that all of us have been speaking about, that we've been advocating about for years, it's actually given them a little bit more visibility. And the existing disparities that we see concerning access to healthcare that we've just heard about in Toronto, that the access to preconditions for health, such as decent housing and working conditions, access to social protection if undocumented lose their jobs, they're actually only made worse in a crisis like this. So on the one hand, we've seen that, especially in the European context, when all of the governments were trying to figure out in the early lockdowns, how can we help all of our workers who are losing their jobs? How can we help them with unemployment? How can we give maybe one-off pandemic payments? All of this was excluded for undocumented because they didn't have regular status. We did see some cities in the US that worked together with NGOs and foundations to grant cash payments directly to undocumented to help offset that a little bit. And we also saw, thanks to the research actually, Nico, that you and your colleagues have done at Compass, that a number of cities have also done similar measures. Where we have some cities and regional governments that tried to provide some limited assistance, but basically in general, undocumented overall were excluded from all of the relief that the pandemic, that governments were giving due to the pandemic. And we also saw that we all rely in our economies on migrant workers who work in very precarious situations. But at the same time, we also saw some responses, and we saw that measures governments are capable of passing when there is a sufficient need. So many countries in Europe automatically extended their visas or their residence permits for people who couldn't renew them because offices were closed and locked down. Italy and Portugal had 2 regularizations. That's really significant in the European context because regularization in 2006, when Nicolas Sarkozy was Minister of the Interior and France had the presidency of the EU, regularization was almost banned from the EU. So if we can consider 14 years later, 2 major countries have regularizations, it really is significant. Ireland had a policy to put firewalls to enable people to get access to healthcare without being deported or fearing that they could be deported. And they also allowed their pandemic payment in Ireland to be for people who are undocumented. So it's been an opportunity on the one hand to get more visibility for some of these things which have seemed somewhat marginal, such as regularization or firewalls. And what PICUM has been doing has been trying to map all of these developments, trying to understand them, and also just see how we can share this knowledge and also try to influence the debate. So we've also been doing this through a lot of reports, through the mapping, and through a number of webinars. And I think that what we need to do now is to try to make the case to go beyond these temporary measures that were during the lockdowns and in the pandemic overall to more sustained action so that we move from kind of this crisis mode to more longer term responses. We do hope that the arguments would have more resonance in the current context, but we know that there's also risks. For example, there's resentment towards migrants as the economic recession creates more pain for broader swaths of society, and governments might also refocus some of their budget priorities. And just to maybe say briefly, this week within PICUM, we're actually running some workshops with our members and with some communications experts to see how our members can better communicate and advocate for the right to health for people during the pandemic. And what we've heard so far is that some of our members have actually felt that the lockdown has offered different opportunities. So even though they can't meet some of their government officials face to face, they actually sometimes have more access to them now online. And it also created an increased impetus to put pressure on some governments because the NGOs had to close some of their services because of lockdowns. And so there was still a need. So that was giving a bit more pressure on governments. So we've seen some very small silver linings kind of in the whole pandemic.
Thank you, Michelle. And I like how this resonates also with what we heard from Canada, that the pandemic actually offered some good opportunities in these areas, but you also mentioned challenges like resentment against migrants. And so to go back and make the link with the previous intervention, I also want to ask you the same question, building on these opportunities, how do you think that we can build a political consensus with different audiences for campaigns that actually extend the rights of migrants to healthcare, including and considering the renewed awareness that the COVID-19 pandemic has brought in?
Mm-hmm. So our work is actually mainly towards the EU and the UN bodies. And in these 2 actors, we've been trying to really show what the impact of the pandemic has been on undocumented migrants, and to make recommendations for all the policy responses going forward to be very inclusive. So maybe just highlighting some of these things. At the EU level, the EU adopted just at the end of the summer the COVID recovery package, and it gave an additional 55 billion euros in what is called the REACT EU package. So this money is going to be added for the next 2 years for EU member states to tackle the impact of COVID-19. And the money is actually funding which is channeled through 3 existing EU funding programs called FIAD, ESF, and ERDF, which is Regional Development Fund. So this funding can be used to provide support to health systems. It can help enhance access for vulnerable groups, including migrant children. So there is a possibility that some of this funding could be directed towards undocumented, but it would have to go through these kind of current funding schemes. And the only one now that currently allows funding for undocumented is FIAD. It's food for and action for the most seriously deprived. So there is some possibility there. But what we really see, and so that's possible and that's maybe positive, but what we really see that the place for change is really at the national and the local levels. And the national level, in terms of legislation and policy that can remove restrictions on access that exist in most EU member states for undocumented people. And what's maybe interesting is what we hear from our members as arguments which have been helpful towards their own governments. So sometimes their own governments are interested in what the neighboring countries to that government are doing. So for example, Germany might be interested in what the Netherlands is doing, or even Sweden, and what arguments they might have been using. And the governments are also interested in making the case on the economic and the public health grounds. We've also seen that the place for change is also the local level, which is obviously the focus of this webinar, where these community-based initiatives are often instrumental to facilitate delivery of care to people who face exclusion and to build support within communities for greater inclusion. So what we've found that works the best sometimes at the local level is arguments that speak to values of inclusion and community. It's interesting. The More in Common organization did a survey recently of 14,000 people in the US, the UK, France, Germany, Italy, the Netherlands, and Poland. And in this recent survey, More in Common found that the pandemic has revived a spirit of localism. There's greater pride in local communities, and there's less erosion of trust in local governments than there is currently in a number of those countries on the national level because of how the national level governments had handled their own policy responses during the pandemic. So in a sense, it kind of just increases our trust in the local level. So I would say that in terms of trying to build arguments, build campaigns, we've seen in different countries, like Sweden, for example, in 2013, when they revised their law on access to healthcare, there was a lot of focus on human rights and the right to health. There was a visit of the UN Special Rapporteur on Health at the time, kind of a shaming, comparing Sweden's situation to other EU countries. In Finland, we've seen success in building in a city-by-city approach. So now basically all major cities in Finland provide access to healthcare for undocumented, and focusing on like building an infrastructure and consensus on the need to ensure people who are undocumented could have access to healthcare. In France, the gains had been adopted more at the national level, and these are already several decades old. So there's legislation already that has existed for almost 20 years or more, for providing access to healthcare for undocumented people. Every year it's challenged by the far right, but there are broad coalitions in France of NGOs, health NGOs, migrants' rights NGOs, and health experts that always come together on this. So I would say in general, there's different ways that we can go about it, but we can never assume basically that probably it's only possible on one level. Usually all levels are equally important. So local, national, regional, as we've heard, for example, with Ontario, regional within the country, as well as regional in the European space at the EU level.
Thank you. Thanks a lot, Michelle. Well, you already burned what was my next question on the role of cities, that cities can have in helping access to healthcare for undocumented migrants. So I will turn into another question, because I know that PICUM has been doing a lot of great work on firewalls, and maybe you can tell us a bit more about that, in particular, how we can counter, can we counter the interoperability of databases that use healthcare as a site of border control, meaning how do we avoid that actually access to healthcare is used for immigration control purposes rather than for a human rights aim?
Mm-hmm. So we've seen this development, I would say, kind of on two levels within the European space. One would be the national level developments in countries such as Germany, which have had a policy for almost 2 decades now that requires professionals in the health space, unless they are the emergency professionals, but requires other professionals to report undocumented migrants to the health authorities. There's also been, to the immigration authorities. There's also been the whole hostile migration policy in the UK that was developed for many years that really requires undocumented migrants also to be reported. So a lot of these national level developments, but now what we also see in the more recent years at the EU level is the use of large-scale processing of personal data to further criminalize migrants. And this is something that you had just mentioned, Nico, which is called the interoperability framework. And basically it's various migration databases that are connected. So there would be creations of interconnections amongst 5 different databases that are concerned with very different things. So for example, visa applications from outside the EU to come to the EU, asylum applications in the EU, a database that deals with dual or EU foreign nationals with criminal convictions. All of these different databases have different functions, but the goal is that they, in a sense, speak to each other. They're interconnected or interoperable. And the whole reason is to then support the national level police and the border authorities to tackle irregular migration and serious crimes like terrorism. So not only do we feel that these enormous databases only target migrants from outside the EU, but they also make this link between being a migrant and being involved in serious crimes like terrorism. And we saw some shades of this last week or the week before with the 13th of November Council of EU Statement of Home Affairs Ministries and the recent terrorist attacks that took place in France, which conflates migrants with terrorism. Another development concerning migrants' personal data is the new EU Pact on Migration and Asylum in the screening regulation. So in the EU Pact on Migration and Asylum, there's, I think, nearly 10 new regulations. The screening regulation is one of them. And basically in this one, in recital 26, article 9, it says that a preliminary health exam will be carried out on people who have to undertake the screening at external borders in order to identify people who need emergency health care or who should be isolated due to public health reasons. So this preliminary health exam will be carried out by health authorities of the member state, but the police can also decide not to carry it out if they don't think these health checks are necessary. So on the one hand, it could actually be seen as positive that the ability to receive emergency health care at the borders could help someone who might have really potential life-saving issues that they need health attention for. But I think what we need to be aware of is where there's problems that are occurring at the borders already, even without this new policy, that interfere, I guess, with migrants' personal data and health in the borders. And just maybe one example, in Italy now, migrants from outside Europe who've tested positive for COVID are transferred to what they call quarantine ships, even if they've been coming to the borders and even if they've already been residing in Italy. And some reports are showing that that those who have regular residence status even are caught up and taken to these ships. There was a case of a 15-year-old boy from the Ivory Coast who died recently after being put on these quarantine ships. So I think in general, what we're concerned about at the borders is underlined by the UN Special Rapporteur on Contemporary Forms of Racism, who just 2 weeks ago published her report on racism and the use of emerging technologies at the border. It's a very good report. Her analysis shows that technology is never neutral. So it's always influenced by individuals creating algorithms, et cetera. And so then it's never neutral in the migration context either. So basically, what we see and how we should address this kind of issue, the first step would be to counter such practices by shedding light on them. So many migrants' rights organizations are, I don't want to say oblivious, but don't follow the debates which are extremely technical and which are basically in the realm of privacy issues. So we see a lot of divide, actually. There's a whole range of civil society and specialized institutions following the whole privacy debate. And then there's a whole group on migration and migrants' rights issues. And basically, these two need to come together a little bit more. So we need to do more awareness raising and engagement of grassroots organizations, and also the people, the migrants themselves, who are most affected by intrusive technologies, as well as people who are helping them, like lawyers and data protection authorities. And I would also add journalists to help unpack a lot of these issues, not only for those two groups of communities and the migrants themselves, but also for the general public, so that we can all basically understand how we're all affected by this.
Thank you. Thanks a lot, Michelle. And I'm sure if you have any publication of yours on these technical issues and you want to share in the chat box, I'm sure many participants will find it very interesting. I'll give the word back to Bruna, who will introduce our next speakers. Bruna, you're there?
I'm here. Thank you so much. Thank you so much, Michelle, for all your work. Back to North America, I would like to introduce Laura. Laura Melgarejo. Yes, Laura was born and raised in Mexico in the state of Michoacan. She migrated at the age of 14 to the United States. Laura is the first generation of her family to attend college and the first organizer in her family as well. As a student at San Francisco State University, she received a scholarship from the Chicana Latina Foundation, and she was a member of the Youth Empowerment Fan Advisory Board of the Department of Children, Youth, and their Families. She holds a Master in Public Health from San Jose State University. Laura was active as a volunteer in efforts to pass legislation AB 540 that allowed undocumented students to attend college and pay tuition as California residents. In 2003, Laura was recruited as a youth organizer for the Common Roots Youth Organizer Program. She works on environmental health, immigrant rights, and language justice issues. Welcome, Laura. It's a pleasure to have you here.
Thank you so much for having me, and thank you so much for all the other my colleagues, the other panelists who share very valuable information and ideas of even some of the work that we can start doing here in San Francisco, California, where I'm at right now.
Thank you. My first question for you would be, in what ways has COVID helped or impacted your work at all?
Yes, I want to echo some of the ideas and sentiments that my colleagues already share in terms of the impact that we have seen in our community. So as you mentioned, I'm a community organizer here in a nonprofit organization in San Francisco, California, people organizing to demand environmental and economic rights, or poder, as we like to name it. And a lot of my work has to do with helping and supporting our immigrant families on our every day when they need support with access to various social services in the city and county of San Francisco. And the primary thing that we have seen as an organizer here in the Mission District is that many of the families that we work with are classified as essential workers. So many of them, despite the pandemic and maybe even their personal needs, still have to go to work every day to support themselves and support their families. And so a lot of the community organizing work that we used to do here at Poder with our families and our elders, our children, was impacted by not being able to have those like community outreach and strategy meetings anymore. So I should say that my perspective in terms of access to healthcare and access to other social services comes from an organizer's perspective, comes from a working for 20 years in a nonprofit organization where we work with our base, with our membership, and we see all these issues that have to do with access to healthcare, access to better education, access to housing, access to all this basic human needs and resources that many of our families have, but because of their immigration status, we know that they're struggling. So going back to the question, because of the pandemic and COVID-19, the COVID-19 pandemic, a lot of the work that we used to do with our families, organizing and advocating for better policies in our city and at the state level has been impacted. And one of the things that we have also seen, that even though we want to continue to organize and continue to move forward our agendas and policies for the better and the well-being of all San Franciscans, and especially and including people of color communities, communities of color and undocumented communities, is that there's a real digital divide in our community. So even though we want to continue moving forward some of the policies that we know are important for our community, it's been very difficult to engage and stay and stay active with our community due to the high digital divide, where our families either don't have access to internet, don't know how to use some of the tools. Sometimes they're competing with their children when they're using they want to be in a community meeting, but at the same time their children are now learning from home. So those are some of the barriers that we have seen in terms of how the pandemic has impacted our work. And definitely, as I mentioned before, we have definitely seen how many of the families, the undocumented workers, immigrant families that we work with and we organize with here in San Francisco, are a frontline essential workers who unfortunately have been impacted in the way that many of them have tested positive. And I think I can talk a little bit about the efforts that we have done, or here in San Francisco, how the city and county has responded. Because a lot of the families that we work with are immigrant families and essential workers, and having to go to work every day and putting themselves at risk, we start seeing really high numbers of families being impacted and testing positive for COVID-19. And because many of them, as we're talking about today, have no health insurance, no coverage, or any type of access to healthcare, we needed to start organizing, and we needed to start talking to city departments, especially with the Department of Public Health here in San Francisco, to ensure that for families that still need to go out and work every day, that we have access to community base or neighborhood testing sites, so that families can go test it and get their results in a way where it's safe, in a way where it's accessible to them without having to use a computer in order to make an appointment and get a test result via email. So we have to do a lot of that work, forming those partnerships, building those collaborations among nonprofit organizations and city departments to ensure that we're responding to the needs of our community, and that we're responding to in a way that's culturally appropriate, culturally relevant, in language, so that our families feel safe. It's very important that regardless of their immigration status, and because of some of our city policies and state policies that we have in place, it's very important that our families know that their data their data is going to be protected. And we can talk a little bit more about that, how we have been able to work around those issues. But yeah, in general, I just want to say that COVID has had a very negative impact, not only on the well-being of the families that we work with and we organize with here in San Francisco, California, but also in the way that we do our work and organizing. This new digital organizing era hasn't been easy, even for some of us who have a college degree. We have to learn a lot of new tools and a lot of new ways in how to do our work with our community.
Thank you so much for your answer. I bet it's very complicated, and hopefully better times come. My next question would be, how do you think we could build political consensus with different audiences for campaigns in order to extend the rights of immigrants when it comes to healthcare?
Definitely. As one of my colleagues was talking about, even when the city, even when our local government or state government has put out some resources in order to support community members who are testing positive and might not have access to healthcare. I want to point out that here in San Francisco, recognizing that many of our families don't have access to healthcare or have very limited access, we do have some programs in the county of San Francisco, such as Healthy San Francisco, who are actually a local program that provides access to primary care for undocumented families or low-income families, regardless of their immigration status. So having that funding and having those resources available, making that commitment, our local government, making that commitment to ensure that we have a program to provide basic primary care access to immigrant families or San Francisco residents is a huge, is a very important step that we made forward a long time ago. That we took forward a long time ago. And also going back to this building leadership, building collaborations and networks of our local government with our nonprofit organizations, with city departments, to ensure that we're all working together for the same for the same purpose, for the same cause. And I was gonna also mention, as we know, now that when the pandemic started and uninsured individuals wanted to get tested, it was very difficult to have access to those testing sites, again, because digital divide is real in our community. And so some of the things that we did to ensure that we provided more access to undocumented families, or just families in general who have those barriers of not having access to internet or a computer, we started collaborating with the Department of Public Health to ensure that they will bring a convenient testing sites to neighborhoods so that families can go directly to them. And the other point that I would like to make is that it's also really important that we build those relationships and collaborations amongst the city departments, nonprofit organizations, and our city government. But it's also very important to ensure that we allocate the financial resources that are needed in order to provide basic, like, access to healthcare and for undocumented or uninsured individuals. I was just gonna mention, like, when the pandemic started a few months later, also the government of California created a relief assistance program that provided some funding for undocumented families. At the federal level, when the federal government provided some resources for all people in the United States, undocumented workers were excluded. They were not included in the packet to be able to get some stimulus money to be able to sustain themselves during the pandemic. However, California and here in San Francisco, we created other efforts to ensure that families will have access to financial support or financial resources, recognizing, again, that many of the community members that we work with are essential workers. And even more important, knowing that they're essential workers, we wanted to ensure that they have access to healthcare or access to get it tested, because they're getting out of work every day, putting themselves at risk, and working with the communities to ensure that they have some basic information about the pandemic, how to take care of themselves, how to take care of our community, how to take care of their neighbors. And very briefly, I want to mention that recognizing that in California, even though we created the program that I mentioned, that California Relief Assistance for immigrants, to provide some financial support. In San Francisco, Empoder was part of this effort or collective. We also created a DocuFund program to ensure that we will going to be providing some financial resources for undocumented individuals in the city and county of San Francisco who needed financial support to be able to pay their rent, but also to be able to even afford to eat, recognizing that there's so many other needs, not just access to healthcare, but basic needs as like paying their utility bills or getting so behind in their rent, especially in San Francisco, which is a very expensive city to live in. So yeah, that's like a little summary of like some of the efforts and the things that we have created. So to ensure that people are collaborating and to ensure that we're working together to serve the needs of our immigrant families in San Francisco.
Thank you so much, Laura. As you were talking, I was just nodding my head and comparing it to Toronto. Nico, do you want to proceed?
Yeah, sure. Thank you. That's all very interesting, and that's actually interesting how, you know, what you've been saying and what the previous speakers have been saying actually resonates across the cities, across the continents, across countries. You know, we've heard like, you know, how countries in Europe have even regularized the status of undocumented migrants because finally there's been a recognition of the fact that many of them are essential workers and they're needed now more than ever. So we'll see if this new wave of awareness will change perspectives on a longer time. But for the time being, we'll go back to Europe. We've heard a lot about the EU. We'll still hear about a European country, but not EU. And we will be dedicating our two last contributions to the situation in the UK. I will start welcoming Jessica Potter, who is a doctor, a researcher, and a campaigner in London. As a doctor, she's working in London as a respiratory specialist. I think a very much needed doctor in this period. But at the same time, she's a researcher at Queen Mary University in London, where she's been exploring the link between people's experience of healthcare and the structural inequities that shape these experiences, specifically racism and xenophobia. But Jessica has also been a campaigner with several grassroots organizations, including Docs Not Cops and MidAct. Her campaigning has been focusing on healthcare rights of migrants, and more broadly, she's been campaigning against racism in the UK's national health system. Because of this engagement, she was presented with the Champion Award in 2019 at the Women on the Move Awards for her work on the Patients Not Passports campaign, which is a campaign aimed at ending immigration controls in the UK's national healthcare system within the context of the UK's hostile environment policies. And I'm sure that we'll be hearing a lot about hostile environment policies in the UK and how they've been preventing undocumented migrants from actually accessing healthcare in that country. Jessica, are you there?
Yes, hi.
Hi, great. Okay, let's just continue on the same kind of stream. Like, how has your work as a researcher, a campaigner, and a doctor been impacted in 2020 by the pandemic? And how have you seen that the pandemic has impacted on undocumented migrants' access to care in the UK, especially within the context of a restrictive policy context as the one of the UK's hostile environment policies?
So good evening, everyone, and thanks very much for joining, and thanks for inviting me to participate. It's been excellent hearing from everyone else across the world and the similar experiences that I think we all have shared. With regards to the NHS, just very briefly, in terms of how people access healthcare here, we have a health service that is designed to be free at the point of access, and it was built on the foundation that it was free at the point of access to anyone who needs it. Behind that set of values sits the NHS charging regulations, which restrict access to people who are considered usually resident in the UK. And that used to be anyone who was visiting as a tourist or undocumented migrants were chargeable for NHS care. over years, the recent years, over the last decade, successive additional restrictions have been placed on access to healthcare in the UK on the background of a rise in xenophobia and anti-immigration policies in general. And it was through this kind of increasing number of restrictions that and changes to charging regulations, further excluding people from healthcare here, that the Patients Not Passports campaign was born and Docs Not Cops started. So Docs Not Cops is a grassroots organisation which was formed to campaign against the charging regulations and restrictions to healthcare access for migrants. We are a group of not just doctors, in fact, we're a wide range of nurses, doctors, midwives, advocacy people, people who are not born in the UK themselves. We are a diverse group and now working across the UK landscape. And the Patients Not Passports campaign is a broader campaign which was designed to bring in lots of different actors in this field, lots of different campaign organisations, so that we had a common goal of trying to challenge the hostile environment in health. The hostile environment policies that Nico is speaking of consist of a range of different measures, such as posters telling people that they're not eligible for free care, as well as more overt barriers to care, including overseas visitor managers who go around hospitals trying to detect who is not eligible and charging those people. So I won't go into too much detail about the regulations, but in relation to Nico's question, how have things changed during COVID? Well, clinically, there has been, we had a very challenging time over April where all of our healthcare services were disrupted because of COVID. What that meant in practice was that huge amounts of resource was focused upon managing COVID, and that left a lot of other people not able to access the healthcare that they need. And for example, migrant screening programs for infectious diseases were put on hold. It made in terms of pros, there were fewer overseas visitor managers on the ground going around trying to detect people who were chargeable for care, because it posed a risk to them to be in the hospital environment. And so I suppose that was a kind of benefit, although it also probably led to an increased reliance on digital systems for screening. And I know that we can talk a little bit about that as well. It's also made access to interpreters really challenging, again, because people can't come in, and that is problematic for our patients, and access to GPs in addition. In terms of advocacy work, we had a big meeting as Docs Not Cops towards the end of the last year, a strategy meeting. We had big plans for this year with regards to direct action and local organising campaigns. We hit the year running with a really great piece of community organising in East London, which brought together lots of different organisations to campaign against the charging policies of the hospital that was local to that area. And we have not been able to continue that work because, particularly as COVID was announced, we felt that campaigning outside of hospitals, which is some of the work that we were doing, was not appropriate in the context that it would put both those people campaigning at risk, and healthcare workers at the time were under enormous pressure. Didn't need to have to fight their way through, large groups of people outside their hospital, and so we've had to move to more online strategies. But I do think that those online strategies have fostered a wider geographical sharing of ideas with a move to online communication, greater flexibility for people wishing to attend meetings, perhaps stuck at home for a variety of reasons. We do need to recognise how this has impacted access to these spaces, though, for people who don't find engagement with these digital mediums quite so easy. And there's also pro and a con in terms of the link between migration and public health. And I think that it's a difficult link and area to tread. We know that we can use public health as an argument in order to ask for healthcare for all. However, there is a historic negative association between migration and disease that we need to do our absolute best to avoid. It's helpful that COVID has, affected many different types of people, although as Michelle from Pekin pointed out, it's certainly not affected those groups equally. In terms of research, documenting harms that are happening to people is much more difficult because our access to these groups is hampered because everyone is distant from each other geographically in their own spaces. And in addition, access to the healthcare setting for researchers who are non-clinical is more difficult because of COVID and the restrictions placed around those their access. There has been more money in research aligned with COVID and also in association with public health, and hand in hand that goes with healthcare access. And so there are ways in to help use this type of money to make visible the harms that are occurring.
Thank you. Thanks a lot, Jessica. And probably just a quick answer to one last question, because Michelle before has been talked about interoperability of databases, and she's made the example of the UK as, the hostile environment policies are also around the concept of healthcare workers sharing information about patients' migration status. Can you tell us a bit more about what we think that we could do to counter that, the fact that patients' data shouldn't be shared with immigration authorities?
Yeah, I think that I'm going to refer to Pekin's firewall work on this. I think the firewall is absolutely vital between healthcare and immigration services, and that is not what's happened in the UK. In fact, there was a data sharing agreement between the NHS Digital and the UK Home Office and Border Control, which allowed routine data sharing. And indeed, some of the people that I've interviewed as part of my research were in fact arrested on hospital grounds because their clinic time was shared, and that is completely unacceptable. People must not be afraid of accessing healthcare. There was some intervention at parliamentary level with our Health Select Committee holding hearings with really strong intervention from advocacy groups to argue that this is not appropriate in relation to confidentiality and healthcare, and confidentiality being, a cornerstone of a good health system. And I think that was effective in shutting down at least the routine data sharing that was going on in that setting. However, there are a number of different other things going on now in light of COVID. So we've got track and trace, which people are very worried about how that data is going to be used. Those worries hamper our ability to manage public health, and unless we have a firewall, then it is not unreasonable that people would be afraid of inputting data, downloading that app, and that those kinds of resistance and organized resistance are things that I can foresee across a number of different advocacy groups. I think the other thing is making things visible. The problem with digitization and the people using the routine data that's collected to identify chargeable people or to pass on their details, it's not visible. And, as Hannah Arendt talked about, bureaucracy is very dehumanizing. And we must remember not to blame these individual actors who are doing these these jobs, but make visible exactly what harm is being caused at the end of each and individual action that leads to this kind of structured discrimination and harm.
Absolutely, absolutely. And I think that, you know, the trace and contact efforts and the need to, you know, just build interactions with the population must be an alarm bell for everyone to remind us all of the importance of not creating a wall of fear for people who live in a country. And we all know now better that if people are scared to be in touch with the authorities, it's problematic. It's problematic for those people, but it's problematic for the wider population in general.
And broadly in relation to kind of public health, you know, we've been challenging these ideas of control, disease control, and the restrictions that are placed on people for a really long time in the, you know, academic and also advocacy world. And it really feels like we've gone back 20 years with COVID, and I'm fearful about the restrictions that COVID will bring and the additional surveillance and the dangers that that holds.
Yeah, and you know, and also the efficiency of surveillance through fear, it's questionable at least. But thanks a lot, Jess. I'll now welcome our last speaker, another speaker from the UK, so she can continue on the stream that we just opened on the UK on the hostile environment policies and on migrants' access to healthcare in the United Kingdom. I would like to welcome Aliyah Yule, who works at Migrants Organize, which is a charity based in West London that offers a platform for migrants and refugees working for dignity and justice. Migrants Organize also provides holistic individual support and advocacy for migrants alongside running a migrant organizing program where the organization works on building capacity and leadership to take action against hostile immigration control. Aliyah is the organization's Healthcare for All Migrants organizer, and she's been working on the Patients Not Passport campaign, which we've heard on, which, as we said, is a campaign aimed at ending immigration controls in the UK's NHS. The national healthcare system of the UK. Aliyah is a long-standing advocate and campaigner. Before the Patients Not Passport campaign, she's been working in a number of campaigns, including on migrants' voting rights and immigration reform. At the moment, she's developing a direct action casework model to support individuals excluded from or charged for healthcare to take action and build community-led campaigns. As we speak, we will be sharing links to these campaigns and to the related reports, including one that she has co-authored on the international struggle for universal healthcare. Without further ado, I will now leave the floor to Aliyah.
Thanks so much, Nico. And thank you to all the organizers for bringing together what has been an extraordinary and really important panel. It's always a real honor and a little bit of a daunting task to come last after all of those incredible contributions. And I've learned so much already.
Yes. Sorry. Yes. No. So we've heard a bit about how COVID has impacted in the UK. Maybe I can ask you another question that we've asked other speakers before. And what is your opinion on how we can build a political consensus with different audiences for campaigns to extend rights for migrants to healthcare?
Yeah, thanks, Nico. I think it's a really important question, and it's something that we're doing all the time with the Patients Not Passports campaign, which Jess already spoke about. And I think it's really important to think about the context in which we are campaigning and working for access to healthcare for all, which is in the context of this hostile environment where the government has embedded immigration control into every aspect of migrants' lives. pushing undocumented migrants deliberately towards destitution and towards exploitation. It's designed to make life unbearably difficult for undocumented migrants, to criminalize them. And it also has wider implications on all migrants and racialized communities in the UK. And I think it's really important for us to think about how the hostile environment immigration policies seek to turn everyone whose role in society it is to care and support the most vulnerable, all public sector workers, into border guards. And so I think the Patients Not Passport campaign begins from the basis that everybody who has now, under the hostile environment, been recruited to be a border guard, we must now recruit to our campaign to be fighters for justice, for equality, to stand up for everyone's rights, including to access healthcare as a human right. And so what our work is doing is trying to build a kind of mass movement across the country to resist the policies. And that does require appealing to lots of different audiences and at lots of different levels. I guess I wanted to talk about a couple of the main strategies of the Patients Not Passports campaign as to how we do this. One of them being the direct action casework network that you mentioned, which is about building community-led campaigns at a local level around and with individuals who are struggling to access healthcare, are being charged for healthcare. So one example is in Sheffield. We work with a guy called Simba who was charged £100,000 for his healthcare. He is, as a refused asylum seeker, he's denied the right to work in this country. He wasn't able to access healthcare, which would have benefited him and prevented him from having a stroke, which resulted in him needing this extremely expensive brain surgery and treatment afterwards. And Simba sort of turned around after this bill was presented to him and said, this is another way that the Home Office in immigration enforcement is being used to bully me, to make my life impossible. And so Simba, with a number of different organizations, built this campaign around him. He told his story about how he's lived in the UK for 15 years, about how his father's immigration status has been refused by a racist immigration system, and how that had impacted him, and really built links and embedded himself inside a community, which is then able to stand with him. And importantly, with a lot of health workers in the local community who were then able to raise his story in their local NHS trust, which is the body that kind of oversees healthcare in different localities in the UK. And that was really important because so often what happens with these policies and the impact of them is invisible, and they're designed to be invisible. The hostile environment works by invisibilizing undocumented people and making it incredibly difficult for them to speak out without fear for their immigration status. And so, Simba's campaign has been remarkably successful in building alliances with many different groups, football groups, healthcare workers, local trade unions, local political parties, and others to kind of say that the overall healthcare system, which denies access to undocumented migrants like Simba, must be resisted overall. And I think something that's, touching on one of the other questions that is asked this evening around how coronavirus has impacted the work, organizing in this way with communities and individuals who are on the sharp end of the hostile environment has been extremely difficult during the pandemic. Mostly because the situation for a lot of people is so extreme and desperate, with regards to housing, with regards to access to public funds, with regards to access to healthcare, and many other things. And even things like accessing the internet, having phones. I mean, migrants organize a lot of our work at the beginning of the pandemic was providing computers, phone credit, data, just to make sure that our members and the people that we work with can continue to stay connected to their communities with us, and won't fall off the sharp end. And so it's been really hard. But I think what the pandemic has done is really, and I think a lot of the other speakers have sort of touched on this, is focus the kind of public attention on the reasons behind health inequalities, so that in Simba's case, we can start talking about, in a much kind of wider and more recognized way, the fact that what's happened to him is as a result of structural racism that has created this condition for him. I think, you know, the fact that this has all happened at the same time that the Black Lives Matter movement has been ignited across the world, it's really sharpened people's minds as to these, the causes of health inequalities. And because, you know, there is unequal access to housing, workers' rights and protections, and that disproportionately migrant and BME communities and also undocumented migrants are key workers, are the people on the front lines who are poorly paid and poorly protected. And I think that's been really, really useful and sort of eye-opening for so many in the pandemic.
Thank you. Thanks a lot. I guess that we have a bit less than 10 minutes for a final reflection with all the speakers. I remind everyone that there's a Q&A button where some questions has been asked and answered. I'll let Bruna take it on. I invite all the speakers to turn their camera on to make this last reflection all together. And I thank you already, all the speakers.
Thank you everyone for your perspective so far. Our last question, and you guys can go in order as you guys please. What narratives have worked or not worked regarding framing precarious status residents as deserving of healthcare? Are there any dangers in framing our campaign just for essential workers, for example?
I can start with some of the narratives that I have found helpful. I think that even pre-COVID, some of the narratives that have been really helpful in our advocacy has been really humanizing the person behind the immigration status. A lot of people come in with these preconceived notions of what it means to be living in a city, being undocumented, and humanizing the person and explaining the circumstances they are in has helped me advocate on many different levels, whether it be to get access to immigration status or healthcare. I think humanizing people really helps, in my experience anyways. Also, when you're advocating with hospitals, I think it's really important to talk about preventative care costing less than folks showing up in the emergency department, and also the argument of having bad debt. The hospitals at the end of the day are a business and they want to get paid. So to argue to work out payment plans or waive fees and work out a feasible amount that people can pay versus having these bad debts sold to collection have often been really helpful. Of course, you know, naming healthcare as a human right versus a privilege is great. And also using the strategy that we are in fact a sanctuary city and recognizing that we do need to have healthcare access for folks who are living here. Thanks.
I agree with a lot of what Nadia just said, and you know that we've used a lot the call that healthcare is a right, not a privilege, in many of our much of our work. I think one of the things that really you talked about, Bruno, you talked about deservingness. If you look across the media presentations of people who've had their healthcare access restricted in the UK, where we've managed to make those stories public and humanize those people, the challenge of that, of course, the humanization and its intersection between selling that person as deserving. And actually, I think we need to move totally away from this deservingness angle and much more towards healthcare as a right and a public good, good for everyone, good for local communities, good for the globe, good for the country, good for the individual. And rather than this idea that someone deserves healthcare because as soon as we do that, we fall into a huge trap where deservingness can play out on so many different levels, not just with relation to immigration status, but individualized behaviors. And I think that that's a narrative we really need to strongly challenge. The second point I was going to make was the financial angle. We've really, initially we started our campaign talking a little bit about how it wasn't cost effective to find and charge migrants, but actually, even though we still believe that to be the case, we actually don't think that a cost effectiveness angle is actually helpful, because again, it detracts from this idea that health is a right. That's all I had to say.
I can maybe add just to support Najla and Jess in terms of all of those arguments are ones that I think PICA members have used in different countries and also questioned. As Jess says, the financial angle, many of our members have used it and also questioned it because you don't want to reduce people to their economic value in a sense. And I would also add that what was interesting, I think, as long as PICUM has existed, we've accompanied the whole development in Sweden because the Right to Health campaign in Sweden started, I think, in the late 90s. And then this whole campaign basically had been going on the whole time that we've existed. And so it was, and basically at the heart of their campaign was what Jess was referring to as the healthcare as a human right. And that whole focus actually worked quite well in Sweden at the time. I think that's what we should also consider is what works at a certain time. That's a very strong argument, but it had a lot of resonance when it was being carried out, I would say around 2000, the mid 2000s. It might be difficult now to get a lot of traction, and it doesn't mean that we shouldn't base all of our arguments in the human right approach. I completely agree with what Jess has suggested as an approach. But I think it's interesting also if we look back at some of these other countries' laws on healthcare for undocumented. Basically, Belgium, France, and Italy are from the late 90s. And I think that they all probably had a similar approach in using the human rights angle of healthcare. So I think a lot of, and those laws were passed by legislators. So they had traction from the lawmakers in a sense. It would be interesting to see if there would be, like in the UK now, it was interesting to hear about some of the political parties' support for some of these campaigns and what actually resonates the most with them now. Nowadays, like in 2020 or 2021, what do we find gets the most traction? But I would say all of these are really valid arguments. And the other one that I think some of our members also draw on a lot is the sense of professional ethics, that it's not a doctor's duty to be reporting people. So so that actually is very strong. I think it's a strong argument that sometimes also has a lot of sway.
I think I can go next. I think as an organizer working for immigrant rights, for environmental justice, language access, and working directly with impacted communities, we always bring the framework of power, not panic. So we want our families, our communities to feel their inner power and to know that they're visible, that they're valuable, and how we dignify their lived experiences. And that has been part of the framework that we have used not only to influence local policies, but also state legislations to ensure that our families feel that their power, and we don't want them to live in fear, and we want them to have a dignified experience, dignified lives where their lived experience are validated and they're not just another number like a database, or they're just this invisible community that they don't exist because they don't have a social security number, but they pay taxes and they do many other things for our economy, for our country, for the well-being of all of us. So yeah, that's been the framework that we always use: power, not panic, to ensure that our families and our communities, regardless of their immigration status, they feel human, and that they don't feel just like a number. And that goes along with like thinking of housing and healthcare and education. Those should be human rights, that we should all be entitled to that, regardless of where we are coming from or our immigration status. So yeah, I want to close with that.
Yeah, I think all of these contributions have been really useful, and lots of the different arguments are ones that we use in the campaign and have trialed, as like Jess has said, and sort of adapted depending on different audiences and different contexts and who's using them. But I think one thing that at Migrants Organised we've been developing is the understanding of healthcare as a right, and how we win that as being part of the need for overall systemic change and much wider change. And so we've been developing this piece of work, which is called the Fair Immigration Reform Movement Charter, which developed out of listening to migrant organizations, grassroots communities that we've been working with for a number of years, talking about all of the different issues and campaigns that they have been working on and organizing around, and how it is that we can unify a movement that calls for all of these different things under the banner of the need for systemic change, to unite a call sort of nationally and in fact internationally for humane immigration policies that truly reflect society's sort of democratic values, that are based on the principles of dignity, of justice, of welcome for all. And I think that kind of unification across different sectors, across different campaigns and people working on different areas, from healthcare to housing to ending immigration detention, is so important and is so needed, in particularly in, as we see the kind of growth of nationalism and the right in this country, and I know in the US things are slightly turning around, but also maybe not. And I think yeah, that unity is something that we need now more than ever.
Okay, I think that was all very helpful. I don't know if Rachel and Graham want to say some last words before we head to a closure, or
Hello. So I just to say a huge thanks to absolutely to you all for such a rich and powerful session. I know we have a run over, so I'm keen to wrap up in case, I don't know whether anyone wants to add anything more from any of the speakers. I think everyone has said everything. Graham, do you want to add anything further?
Yeah, I would love to say thanks to everybody. And my internet tab is just filled with links and files to be reading through. For those of you who are still here and watching, we've recorded this. So if you are interested in seeing the recording or you want to share it with other people, email either myself or Rachel and we'll get that out to you.
Thank you all so much for your time and for holding this space with us, and have a very good day, afternoon, evening, wherever you are in the world.
Thanks to you and Graham for organizing this amazing series of events. Thank you.
It's been our pleasure. It's been our
pleasure, to say the least.
Thank you.